Hello, everyone. I'm Peg Bull-Joni, and you're tuned in to Southern Vermont AHEC's Let's Talk podcast. AHECs are national organizations focused on cultivating and supporting the health workforce, particularly in rural and underserved areas. Today, we continue to examine the topic of health equity, with a particular focus on the social determinants of health. I have the pleasure of sharing the microphone with my special guests from the New England Rural Health Association, Andy Lowe, Executive Director, and Anne Marie Day, Chief Operating Officer. Andy, Anne Marie, welcome to the show.
Thank you.
Thank you, Peg.
We have much to discuss, so let's get started. I guess I wanted to find out first, what inspired you both to pursue careers in rural health? Andy, do you want to start?
Sure, Peg. I grew up rurally. I've lived rurally my entire life. And frankly, I'm not comfortable anywhere outside of rural environments. Rural people, we know, and this is lived experience, have less access to services for healthcare and then social determinants of health and so on. And that's a core health equity issue. So that's really what's driven my interest in that working in this area.
Anne Marie?
I think it's probably similar for me. As Andy mentioned, I've grown up and lived my entire life in a rural community. And I always say I wouldn't go anywhere else. It's just something special about, not just the environment, but the people. And I got my start in rural health at my local community health center. And so for me, it was really like serving my fellow community members and seeing the struggles and things they were dealing with that really drove me to want to help and then to pursue this as a career.
In our discussion, we want to examine health equity on a broader scale, particularly around social determinants of health. First, I believe we must define for our audience exactly what are social determinants of health, and how can you put that into terms people can understand? Andy?
Sure. Social determinants of health are basically the 80% of everything that determines people's health and wellness, exclusive of what goes on in the doctor's office. So most of what determines how healthy and how well our people are, regardless of whether they're rural or otherwise, are the things in their lives that are not clinical, but the factors such as transportation, housing, nutrition, things like if they have access to broadband internet or cell service. All these things can have a profound impact on people's health and wellness.
Anne Marie, do you have something to add to that?
No, I think just keeping it simple, it is really the other factors in the environment and the community that affects people's overall well-being. And so, as Andy mentioned, that can be a number of different factors. And I think for rural, while there are definitely benefits in the environment and community that impact well-being, there are a lot of challenges that I know we'll discuss a little bit further here.
So what are some of the real struggles populations in New England are facing around health equity? And what would distinguish them from other parts of the country? Anne Marie?
Yeah, I think one of the main struggles is the access to healthcare, whether, their local critical access hospital closed or their nearest healthcare is 2 hours away through the mountains and it's winter. So really the transportation issue is always a huge barrier as a social determinant of health, as well as housing. We've found that to be a huge struggle in rural communities in New England, not just New England, across the country, people sort of not being able to find affordable, safe housing. And so I think for rural folks, there's often a lot of invisible sort of equity issues as well. We think it's sort of a culturally, everyone's sort of dealing with the same struggles, but, somebody might not have access to quality education, childcare, economic opportunities. And so there's also a lot of diversity in rural communities that we just sometimes don't see, whether, it's LGBTQ communities, racial diversity. So there's a lot of factors, I think, that sometimes folks in rural communities don't necessarily see in their day-to-day lives, but does exist.
That's something I think that many people are not aware of. It's not as obvious to people if they're experiencing inequity. Andy, what are your thoughts on that?
Certainly, all of that is just so fundamental with what's going on. I think one of the things that happens, Anne-Marie, I think referred to the fact that some of these populations are kind of below the radar. So many people think that our rural areas are populated by all white people, all English speakers, and that's just far from the truth. There are increasing numbers of people, particularly migrant and immigrant workforce, that are serving the tourism and hospitality industry. They may be blowing snow at the ski areas. They may be working on the commercial fishing fleets. They may be in agriculture. That's been going on longer, but now all these other things are going on. So we have lots of people with equity issues. But as I mentioned before, the very fact of living rurally is an equity issue because we have less access to services. And some of these things we'll go into later on, but there are things that people may not think about. Obstetrical services are increasingly, we're having what we call OB deserts in areas where people can't have access to services without driving a long way through the mountains, as you said, Anne-Marie. EMS services, emergency services, we have EMS deserts too, increasingly, things like that. Skilled nursing facilities, we're having so many less beds available. So there are all these factors that are combining to create an equity issue for anybody who lives rurally, but particularly some of these populations that may be not always top of mind for people.
Based on your perspectives, how do you build on their strengths?
So I think rural communities have lots of strengths, and that's one of the things that we all love about them. Rural people look out for rural people, so that's always a benefit. You know, if we see a neighbor struggling, folks will come up with solutions, whether it's a community volunteer transportation system or microtransit. So there's lots of, I think, unique innovations going on around rural. So one of our roles is really to try to help that spread, whether it's connecting folks across states, you know, sharing webinars of best practices, or our large conference where we have breakout sessions and folks can talk about some of these issues and solutions. Not that we have all of the answers, but we, you know, have seen some really great efforts. And I think since rural is really unique, you know, just taking the urban solutions and putting them in rural doesn't work. And so, you know, we've talked about workforce being a huge issue for rural communities, and how do we bring, you know, whether it's doctors, nurse practitioners, nursing staff, even medical assistants and front desk folks to want to work there and be able to afford to live there. So as we've mentioned, housing is a huge issue. We've seen some of our rural communities come up with different solutions, whether it's building their own housing right at the hospital. We have found too that just rural exposure, we've been working with students a lot. That's been a huge priority for us. And so getting those folks exposed to rural communities throughout their education and connecting them with communities that have things they love, whether it's being on the water or hiking, fishing, and those sorts of activities really helps them connect to that community and eventually want to build a home and life there and be able to work and practice there.
Andy, did you have something to add to this?
Yeah, I think one of the things that's really important in terms of some of the best practices is, and Anne-Marie alluded to this, is that these are community-based solutions. So we're seeing greater numbers of community-based organizations with a number of non-traditional partners getting together and addressing these things. And there are some programs out there that are recognizing this and really helping. And organizations like the Federal Office of Rural Health Policy are instrumental in providing funding and guidance and technical assistance to help with these things. And our state offices of rural health in each of our states are such champions of this and such fabulous resources. And there are a number of programs out there that we could talk further in some detail if that makes sense. But doing these things at the community level is really important from the point of view of not being top down, but being more bottom up.
I know when you and I had we spoke about this earlier, you talked about kind of the non-traditional partners. I think that's how you verbalized it. People that you, like you said, in the community that you wouldn't expect that would be supporting these types of projects. Can you illustrate that again a bit?
Sure. this involves going much deeper and broader in the community, and it's not just our community health centers and our hospitals, our critical access hospitals, or our behavioral health providers, or our oral health providers, but some of the folks that you might not think of normally. Law enforcement is a really good example. We have some really innovative projects going on around the New England region, where law enforcement are key partners. And one of the reasons that's so important is they're often the first people to encounter somebody with a behavioral health issue or a substance use disorder issue and so on. And they are acutely aware of the need to bring in effective resources as soon as possible and so on. The business community is really important, business leaders particularly. So much of what we're talking about, it really comes down to being economic development issues, and involving the business community can be a key asset. Also, the business owners are acutely aware that in order to attract the workforce they need, there has to be good, reliable local healthcare. So they are always champions of helping our critical access hospitals, our community health centers, our rural health clinics to become more robust and so on. The criminal justice system at large too. I'm thinking about, we think about people coming out of corrections back into the community. There's a group that faces a lot of inequities and so on. There are people maybe engaging in probation and parole on the other end. So there's so many of these partners out there that are really integral. Veterans organizations, the VA and so on. We could go on, but we want to have a big tent and make sure there's room under the tent for everybody, because it's going to take all hands.
Yeah, well, you're absolutely right. Anne-Marie, did you have something to speak to that?
Yeah, just I think to really involve all of those across the community. One of our projects where we really touched a wide audience was the Rural Vaccine Equity Initiative. So during COVID, we worked really closely with lots of different community partners, both to provide vaccinations, but a lot around messaging as well. And so we reached into the faith-based communities and leaders, municipalities and towns, sort of community leaders, because we felt like those were the trusted folks in the community. And so they really had to help spread the word and share the message. And it had to come from folks within and not outside to be able to spread that.
Well, like it or not, this work takes money, as you both are keenly aware. However, grant funding is often one-time dollars. How do you take one-time funding and transfer it into a durable solution? Andy?
I alluded to some of our partners before, and that's really the foundation of what we do. So organizations like the Federal Office of Rural Health Policy, which is located within Health and Human Services at the federal level, are really innovative in what they do. And there are some programs such as the Rural Health Network Development Planning Grant that's not a particularly large amount of money, but can have profound implications in terms of strengthening and doing capacity building. And some of these investments are really amazing in terms of how they can catalyze change in a community. There's one program that we work closely with where for an investment of less than $100,000, a network of many of these non-traditional partners, as well as community health center, hospital, and so on, were transformed into a durable network that is now organized as a 501(c)(3). They're attracting funding on their own. They're growing and doing projects on their own too. And this organization has just taken off and become a hub in their rural community. That's one example. Another example, we're doing work with a public health workforce program to train community health workers in rural areas. And that's another project that's coming down through the Federal Office of Rural Health Policy. And that was able to harness some of these existing networks and strengthen new networks. So those are both examples of one-time funding that are translated through sustainability, required sustainability elements within the grant to really become sustainable and take off. So I think that's one of the big things is finding these relatively small investments that can translate into big returns on those investments.
And Marie, did you have something to say?
I would say join us at our conference in November. That's actually the theme, so rural sustainability, because I think that's often the case. People get this one-time grant funding, or it's only a year or a couple years, and then the good work that we've all put so much effort and planning into sort of fizzles away unless you do, as Andy mentioned, sort of that sustainability planning. I always say build the business model, because there's other folks that will support the work. One of our main communities, they took I think the same, a network development grant, and supported a community that had 2 hospitals. And so after that funding ended, they had really shown the work that they were doing was reducing readmissions, supporting the patients in the community, and improving outcomes. And so both hospitals ended up contributing to keep this sort of program and network going. And so, yeah, just really thinking towards the future, diversifying funding. There's lots of community foundations, state-based funding and foundations. There's the state office, federal office of rural health policy, HRSA. So there's lots of different opportunities. So it's sort of sometimes braiding and blending funding and thinking long-term of how to create and keep a program running.
Yeah, it must be overwhelming, though, to the people that are trying to do this, to find the money.
It is. So one solution we're looking to do is really to try to provide grant technical assistance and support, whether that's education on how to find the funding, how to apply, how to do grants administration, and how to build some of this sustainability into the project. And so we've recognized that as a challenge because they don't always have the resources or capacity. And so we're looking to get out there and really provide some training and support.
Andy, I know we sort of covered this earlier about the non-traditional partnerships and how to bring those parties together. Do you, I guess, and this isn't one of the things we talked about earlier, but it made me think about hospitals and the future of hospitals turning into specialty types organizations, only focusing on certain things versus serving everybody. Do you think that model is going to become more common going forward as hospitals kind of are struggling financially?
We're seeing that trend with a number of our small hospitals around the region. And we certainly understand why they're doing it, what they need to do in terms of their own sustainability, because so many of them are living right on the edge of solvency all the time. They're looking for reliable revenue streams that can help them not just keep the lights on, but to do more and so on. That can be a little bit of a two-edged sword if they develop some of these specialties and there's not enough demand for those services right in their community. One of the unfortunate things can happen is they can pull people from other regions to come to their region. That can lead to some issues. And it also, unfortunately, sometimes they de-emphasize some of the local services. So it is one of those, as I said, kind of two-edged sword things where we understand that the need to find ways to bring reliable, durable revenue in the doors. But how to balance that with providing the range of core services that people need. We're seeing a trend in some parts of the country to go to what's called a rural emergency hospital. Critical access hospitals are changing their organization to become a rural emergency hospital where they don't have resident inpatients. They basically are an emergency department staffed up to be an ED emergency department. They can keep patients up to, I think, 24 hours is all. And that is, so far, has not gotten a lot of traction in New England. So I think that's comforting in the fact that many of our small hospitals are continuing to offer the full range of inpatient services, which is fantastic. But what's happening is we're just seeing that the economic realities are forcing a number of these institutions to look for revenues wherever they can find them.
Anne-Marie, did you have a comment on that?
I think the only other thing we've seen as well is community hospitals sharing some specialty providers. And so they don't have to foot the bill and have the volume to support, say, a full-time orthopedist, so they sort of rotate around and have different hours at different local community hospitals. And yeah, with the REH, it's hard. There's innovative strategies to try to find models that support rural, but I think, there's other factors to consider and why that's not really taken off in New England, with losing like their swing beds. There's nowhere to also place these patients as nursing homes close, and there's nowhere to discharge them to. Also, with that program, they lose their sort of 340B drug program revenues. And so there's just a lot of factors to consider that I think impact rural communities different when looking at these different models.
Andy, did you have something?
Yeah, another observation about this is we talk about this a lot at our policy committee at the Rural Health Association. It's a frequent topic. And a lot of our folks are convinced that we need more foundational change in this healthcare system that recognizes the realities of rural hospitals and clinics. And that goes to things like payment models that are based on, especially as we go to what's called value-based care with accountable care organizations and so on, population health, et cetera. Those are built on broad demographic numbers. And of course, most of the numbers for a lot of these ACOs, accountable care organizations, live in more urban environments, and that's where the demographics come from. The rural population can look significantly different. It's a much older in terms of median age. They can be sicker in terms of having more chronic conditions and things like that. And so the current payment models are still tilted largely against these small hospitals. So we need some real fundamental change that recognizes the unique stresses that our critical access hospitals and clinics are facing.
Yeah. We're going to be sort of going off into a different pathway right here. I want to talk about youth, about our student population. And Anne-Marie, how can we engage our student population about health equity?
It's a great question. And I think a lot of the academic programs have really started to build that in and including rural. So there's a lot of rural health scholars tracks and different rural health programs. And that's something we've been working hard to connect to all of them. Andy and I have gone to different programs to speak and sort of spread the rural word. Sometimes you feel like we're on the roadshow of rural. But I think sometimes that piece is missing in health equity discussion, as Andy's mentioned. There's a lot of racial equity discussions and economic and income-based issue discussions, but rural as a health equity issue is often left off the table. So we're actually organizing our first ever student summit. And we really wanted to bring students across all academic programs, whether it's clinical, public health, health administration, all together to be able to have some of these conversations of what it's like to really live and practice rurally, and what are some of the challenges that, your patients and community members will be facing. And so I think just the exposure and starting that conversation early. I know some of our programs were even touching down to the high school level, because I don't think you can start early enough. And so just getting that top of mind, they're already often seeing and living that experience. And so also putting into their minds that healthcare could be a career path, because we find that, most people that want to practice rurally or work rurally come from rural communities, just like Andy and I.
Andy, did you want to add to that, or?
Sure. Some of the other things that we work on a lot, and that there's a lot of work going on with our state offices of rural health and some of our other partners around the region, are things like offering rural-based internships, scholarships. We have a number of scholarships, students on scholarships right now, doing rurally themed research and community-based kind of work. And so finding that bridge between what the students are hearing in the classroom and what's going on in the rural communities is really key. And as Anne-Marie said, we know that people who grow up rurally that's the main contributor to whether people ultimately practice. But the next biggest one after that, we can't control always for people who may have grown up rurally, but providing rural experiential learning during their education is the next largest contributor to people ultimately practicing rurally. So finding those ways to provide those experiences during school. We have a number of student members, an increasing number of student members, and they are participating on our committees and providing, they provide such a depth of insight, as well as just they're so exciting to be around because of their energy and their passion. So that's a big piece for us. And then some of the other things we do is we do work with faculty on their curricula. We are also working right now on a rural health leadership initiative to help with perhaps people who are more recent graduates, but they're still learning in their professions and so on. So there are a lot of ways that we can expose people to rural kinds of themes that have a profound impact on their ultimate decision to practice rurally.
Well, that's extremely well said. I have to put a plug in for AHEX because, as you both know, that is something that is our part of our mission, is to cultivate this health workforce and to offer programs and pathways for students as young as middle school to get them excited and engaged in health careers. And then through our C-SHIP program, which is our internship program, the students focus on projects about rural health, about community health. So they've been doing some phenomenal work. We've had this program for 10 years now, so we're very proud of it. And these students, I've interviewed them. They're incredible. Like you said, they've got so much energy, so much enthusiasm, and so much passion that we just want to keep them and just keep them here with us, because they've got so much to offer.
They are a breath of fresh air. We haven't talked a lot about burnout, but that's one of the antidotes for burnout, is to have our clinicians be able to work with students and residents and so on. And Peg, a huge shout out to the AHEX around the entire region. We're inviting them to our student summit to share. As a former AHEC director, I can tell you their AHECs are fantastic, and they are some of our key partners. So thank you for what you're doing.
I was going to say, we couldn't do it without our AHEC partners. We truly, it's a tag team effort, and I think the more that they hear it and from the different angles, the better. And so, I think our rural students really give me hope to just see sort of that drive and passion as they're coming up through their academic and professional careers.
Well, I totally agree with both of you. And before we wrap up, I didn't know if either of you had any final comments.
I just would say that we can't emphasize enough how important it is to get more people practicing rurally, but also to develop our community-based assets rurally to work on social determinants of health and to help address the inequities that everyone faces. So that's what motivates us. That's what gets me up out of bed every day, is trying to figure out how we can get more people working rurally.
Anne-Marie?
I think a key point is to keep the conversation going and keep rural at the forefront. A piece of our work is also advocacy. And so always being a voice for rural, making sure that there is rural funding. More and more we see that there's sort of rural carve-outs or rural specific directed funding. And so that is so important for us to make sure that that's always at top of mind. And so just keep beating the rural drum and having these conversations is so important. So we thank you for allowing us to talk about something that we love and are passionate about, but I think others hopefully will feel that as well.
Well, health equity is a topic that needs to stay at the forefront of our conversations. And in our next podcast, we'll talk more about health and educational equity. This podcast and others are available on Spotify, Apple, Google, and Audible. Just search for Southern Vermont Area Health Education Center on the apps or websites, and you'll find us. Thanks for listening.